Hi all, welcome to the webinar. Thank you so much for joining us this afternoon, or depending on where you are this morning. We will start in about 5 minutes. Hello all, thanks for joining us today, this afternoon, or this morning, depending on where you are located. We will start in about 2 minutes. Good morning and good afternoon, everyone. We will start the webinar in approximately 1 minute.
Hello, I would like to welcome you all to this presentation on scar and pain management for breast cancer-related lymphedema. My deep gratitude goes out to my partners at Bellisse, Jovipac, and BSN Jobst for making these products widely available to therapists and patients all over the world. My name is Leslie Bell, and it's my pleasure to have this opportunity to share some information and observations with you regarding the treatment of cancer patients who are at risk for lymphedema. I've been a practicing physical therapist for 33 years, and for the last 20 years, I've specialized in the treatment of cancer patients and their post-treatment complications. After my lymphedema training in 1997, I quickly realized that the breast cancer patients had a unique set of circumstances, not only in the arm, but in the breast and the chest wall, and that they weren't really being addressed post-operatively. I noticed that sometimes these problems can linger for years. Among the most significant of these is obviously the arm edema, but most commonly associated with chest and breast sometimes. Lymphedema of the breast and chest wall are really common, and they're underdiagnosed and undertreated. In 1997, one of the things that initiated my interest in the breast and the chest wall was that a patient came into me and she told me that she had a migraine in her chest. And she told me that she couldn't tolerate any hugs from her family and her friends due to the pain in her chest. And this was about a year after her treatment had finished. And this affected me quite deeply, as I thought that it was really unfair for someone who had been through something like cancer treatment to not be able to have warm and close relationships with people because people were afraid that they were going to hurt them. Interestingly, she had been diagnosed with radiation poisoning, nerve damage, and other things that they didn't quite know what was going on. And at the time that I was trained for lymphedema treatment, we were taught that lymphedema was not painful. And that's probably mostly true when it's in the arm, although now we do know that sometimes patients do get discomfort in their arms. But when it comes to the chest and the breast, we understand that there is glandular tissue and that's involved, and that's very highly innervated and very sensitive to pressure. I often think lactating breasts. I'm sure that we've all seen arms that look like this, but I suspect we also see some chest walls that look pretty scarred and uncomfortable, like the one that you're seeing in that right-hand picture. Notice too that she also has quite a bit of arm edema. In this little book called Lymphedema Diagnosis and Therapy, I was really quite excited back when I was doing my training that they discussed that the root of the extremity the root of the extremity is the trunk. And there was very little discussion and documentation about patients with chest wall problems at the time. So when I saw this reference, it made a lot of sense, and it actually made me really happy. When we think about it, the breast has the diagnosis, the testing, and the treatment, and it's obviously affected. And because of this physiological interruption, the lymphatics are going to be compromised, at least for a while, if not longer. It can become congested during the treatment and healing, and the lymph vessels can become dilated and stressed. And we never know which ones are going to be chronic and which ones are going to resolve. But it only makes sense that if we reduce the congestion in that area that's been affected, that it's going to preserve the integrity of those lymphatic vessels. There are a couple of people out there that have made some nice statements regarding breast and chest wall edema. And at a conference I was at in 2006, I was very excited to see Dr. Peter Mortimer from England get up and discuss the fact that even with sentinel lymph node biopsy, it had changed the big arm edema, but it had not changed the breast edema problem, and that was probably going to be a continued problem in the future. And then Professor Olszewski, he comments in Joe Zuther's book, swelling of the breast after sentinel node procedure followed by lumpectomy is seen more and more frequently. In the mid-2000s, when I was speaking at a lot of conferences trying to increase people's awareness of this problem, I was speaking at an oncology nursing conference, and I was really amazed that the nurses there had said to me that breast edema was very rare and that they rarely saw it. And I thought to myself, well, I don't think they're looking, and I don't think they're listening to their patients. So I'm really excited now that when I speak at different conferences and I ask people in the audience to raise their hand, and if they see this, almost all the hands go up. A couple of articles that discuss this by Verbalin in 2012. He says that despite good aesthetic results, a remarkable number of patients suffer from lymphedema of the operated and irradiated breast. Interestingly, that can be up to 75%. And there is a correlation between breast edema and body mass index, and that's kind of obvious because that also is straight the case with lymphedema. It's also correlated with chemo treatment and hormone treatment. There is no correlation that they see so far with the level of the node dissection, so it could be a few nodes to a lot of nodes, the bra cup size, and the tumor location. And unfortunately, despite the benefits of the breast-conserving surgery in lots of ways, the breast edema is still a common complication that lowers patients' quality of life. Another article by Verbalen in 2014, in their conclusion, they said that they had identified several possible risk factors for breast edema, namely increasing the irradiated breast volume, increasing boost volume, using photon boost, increasing the breast separation, which I think just increases the beam going through that tissue, a higher density of the breast tissue, a large tumor, higher specimen weight, postoperative infection, and acute postoperative toxicity. And also diabetes mellitus played a part in that. Their prognostic value remains uncertain, and breast edema is a common complaint after breast cancer and radiotherapy. But further research is obviously warranted. So in these physiologic and post-surgical changes, we see that the glandular tissue is affected, the soft tissue is affected, and fat is often removed and moved around to improve the space defect that's created when they remove the tumor. They want to even out the surface of the breast and make it more cosmetically appealing to that patient. Another thing we got to remember is that the breast tissue does not have a muscle pump. The arm has a muscle pump, the leg has a muscle pump, but the breast does not have a muscle pump, and neither does the axilla for that matter. And so we've got to think about, if we're trying to get fluid out of an area, how are we going to get that out? And we can't rely on the normal pump system that we would rely on for the extremities. The axilla is soft and spongy. It naturally retains fluid. And also, again, that breast is full of nerves. Swelling and scarring naturally stimulate nociceptors. Sometimes scars can be thick and disfiguring, like the one that you see in the picture right here, trapping fluid. And also, it can aggravate cording and aggravate scarred connections of fascial planes, creating restriction. And that can create the restriction in upper extremity motion as well, and we know we've got to pay attention to that. Lumpectomy patients can lose a small amount of tissue up to a partial mastectomy with different sizes and textures of scars. And these patients really deserve a comprehensive treatment for their scars, edema, and their pain, whether it's in their chest wall and their arm. The patient to the left of your screen with the large pockets on her sides, that patient had infections and repeated infections in her chest wall on the right side and had to have her implants removed. And unfortunately, that's what was left over. And she had a tremendous amount of pain, and obviously that extra skin was left over, and it is just creating a pocket for fluid. The next patient in the center, this is a patient who actually had a DVT in the left side of her chest wall, and you can see that extra swelling where the arrow is on that top picture. And she unfortunately has a significant amount of pain associated with it. So she actually has a post-thrombotic syndrome going on. And in that lower picture in the center, you can see just how much swelling she gets on the side of her chest wall. That patient also probably is on the lipedema spectrum, so her skin is a little looser and she's maintaining more fluid than normal. And then the picture on the right, you'll see that scar right at the top of that midsection of the breast, and you'll see that she actually had a seroma there that was quite aggravating. She had it aspirated a couple of times, it kept refilling. But that lump of scar tissue there was, I think, creating a block, and you can see the fullness going up into her chest wall. So the dilemma is, with the advancement of treatment for breast cancer patients, there's more and more conservative treatment with a sentinel node biopsy, which is great. And there are fewer nodes removed, but we have to remember that they are the key nodes that drain the breast and trunk. And back to what the number of patients that might get this, you know, the estimates are all over the place. From 20 to 80% of the survivors will have lymphedema, depending on how one measures the edema and where it is. Sentinel node biopsy. We know that the nice thing about the sentinel node biopsy is that they only take a few nodes, and so they're not harvesting as many out of the axilla as they used to. But we've got to remember that those are the primary nodes that drain the breast tissue. And that breast edema is common, and I put edema in quotations because whether it's edema or lymphedema, we need to pay attention. I think we need to pay attention to that, because that edema postoperatively is really painful, just like in a total knee replacement or any other surgical procedure. The edema is part of the discomfort, and it can delay healing. When we look at the watersheds, we can see where the fluid might get trapped. So if we're wearing a bra that's tight and it comes to the inferior aspect of the breast, you can see that with that watershed down at the waist, that can cause some problems. And the watershed also is trying to move things past scars or fibrosis or pitting, edema. I often say that all roads lead to Rome. And that's really how I think of the primary nodal beds. It's no surprise that the bra that's too tight is going to cause some restriction of fluid movement. If lymphedema or edema is present, our goal is to move and transport that fluid out of that area, and a tight band from an ill-fitting bra can disrupt this significantly. This is a picture that comes from a presentation given by Dr. Neil Pillar out of Australia. And he did an interesting little pilot study looking at patients and what types of bras they wear after breast cancer treatment. And if we look at the pictures and the numbers here, he had OTS means off the shelf, so that would be just a regular bra that someone might just come in with, having bought in a regular store. And then he had a lady that would make some custom bras for him. And he took a pressure meter and he measured where you could where you can see the pressure at the straps at the top and at the sides. That was pretty significant. In an off-the-shelf bra, the average strap pressure that he was measuring was about 58 millimeters of pressure. And in the custom bra that he had made specifically for that patient, it was about 30. The side panels are not too bad, but you can see that underneath is still pretty high. He measured the pressures that traditional bras were putting in the shoulders and torso. And then I asked him if he could have those custom bras made for other patients, and he said no, that lady wouldn't do it. So we are excited that the Bellisse compression bra can actually change a lot of pressures in those areas and can be customized to the areas that are uncomfortable for those patients. Another interesting thing he noted was that when one breast fills or is swollen after breast cancer treatment, the opposite breast also filled. So when we're teaching our patients how to do some self-lymphatic drainage, if that's what, or we're doing it to them, then we always want to make sure that we're doing a little bit of drainage on that opposite side as well. He also noticed that when the patients wore the custom bra for a while, that the opposite or non-affected breast went down in edema, but also the affected arm reduced in edema. So it only makes sense that when we decongest the trunk, that we're going to partially decongest the arm as well. So if we look at this picture right here, we can see those lines that we see on a lot of our patients. If you look at the lower picture, you'll see that on the right side, there is not a line, but on the left side there is. So that's something to keep in mind when you're looking at your patients. Make sure that you always look at them from the side and from the back and try to notice whether there's some edema. In the picture on the lower left, on the lower side on the left, you'll notice that above that line where there is pressure mark from the bra, above it is also some swelling. You can see how it's pooching out just a little bit right there. So it tends to pool. So we want to look at the different types of patients that we have and think about how do we individualize the treatment for these patients. So arms are obviously ones that are easy to individualize, but the patients with the chest wall, I think taking care of those scars and taking care of trapped fluid, improving the movement of skin in the fascial planes are also very important. And then the bottom picture, you'll see with the breast, you'll see the cording is coming all the way down from the axilla down to the trunk. And I have further pictures that show that that cord coming down the side of that breast went all the way into the waist. So looking for cording in different areas that can be treated can also enhance the movement of the tissue. The pictures above the breast on the right-hand side are before and after pictures. And I just want to demonstrate that the line that you can see right here across there is actually probably a radiation line, and that was blocking fluid from going up right here. And after about 6 weeks of treatment, you'll notice that that line is decreased and the breast is hanging lower, the nipples repositioned, and the general fullness is improved. And you can also see that from right here, where this is kind of bumped out and kind of deep. And she still has a crease here, but it's not nearly as deep. And that's after just working on the breast tissue. And she didn't really have much arm edema. So being able to treat those scars makes a big difference for these patients. I often call the lumpectomy patients the lucky one. This patient population has a really good life expectancy. They expect a good quality of life too. And Dr. Jane Armour reports in one of her articles that patients don't like to complain to their doctors about postoperative problems. The sentinel lymph node biopsy patients may or may not develop seromas. However, when they do, they can last for sometimes months at a time. And these patients feel guilty about complaining to their their doctors about pain because they're so grateful for their outcome. They're grateful they didn't have to have a mastectomy, but they still have some issues. And often if a patient doesn't complain about their side effect to their doctor, the doctor might not ask. So with early intervention, we have a better possibility of getting these patients feeling better and getting control over their edema. Sometimes the doctors tell them that their problems are going to resolve in a year, kind of regardless of what they do or not do. But a year's a long time, and I do think that we can intervene earlier for these patients and give them some self-care options and improve their quality of life. The other problem I see with the lumpectomy patients is they don't really have a place to be. Oftentimes they're not sent to a medical store for any kind of a better bra for their problem, and they don't quite know what to do. And I hope that we can continue to educate our doctors and doctors' offices and breast cancer centers that the opportunity to look at these patients early on can really help their quality of life and some of their pain problems. And we don't have to wait until it's just lymphedema. Treating that edema early on might actually, I know the word prevent's a hard one to use, but we could certainly decrease the amount of edema that they have later on. So all post-breast cancer healing complications are really not the same. Again, remembering that that breast tissue is glandular and soft, making it vulnerable to scarring. Radiation always causes inflammation and stiffness of tissue, especially as it continues to heal. Scarring is more aggressive the first 6 months, we know that, but it often decreases that lymphatic motility at the same time. These patients will have several types of scars that pass through several layers of tissue as well. And remembering that sentinel node biopsy removes the primary drainage to that affected breast. So I like to think of creating a toolbox for my patients. So not only what I can do for them, but what they can do for themselves. And I think if we had the opportunity for early intervention with these patients, we could help them with some of the side effects that might be coming on that might be a little scary to them. If we anticipate that there's going to be edema and fibrosis, then we can give them some drainage, self-drainage opportunities or some scar tissue management opportunities. And then the other thing is we know that the radiation patients it's slow to heal. And so helping them with some opportunity to redirect that lymph fluid immediately post-operative through the healing process, which can be 12 to 18 months, but really it's up to about 3 years in some patients. And then if they are having some edema problems and maybe some fibrosis or thickening of the tissues, then getting them a well-fitting compression bra and some chip pads that might be able to take care of that thickening, or if they have edematous flare-ups with exercise or other activities. And then letting them know that a hug doesn't actually have to be painful, and if it is, it needs to be treated. So one of the things that I like to do with patients is create this tailored therapeutic approach, as I discussed earlier. And there's a process that I take my patients through of self-lymphatic drainage. And self-lymphatic drainage has some questionable effect to some people. However, the good thing about it is that you're actually giving the patient some control. And I've had the great opportunity to see patients actually reduce quite a bit of swelling in an upper extremity or a chest wall, but especially in the upper extremity where you can measure it better. And in times when they couldn't get their sleeve. So maybe I've got an insurance company that's not allowing them to get their sleeve in a timely basis. It has to be reviewed and then okayed and then ordered, et cetera, et cetera. And that patient's just waiting for this to happen. In the meantime, they've got edema in their arm. And so I was taught a little different way of doing self-lymphatic drainage by a friend of mine in Washington. And what you do is you have the patients do about a 30 to 60 to maybe 90-second process about 8 to 10 times a day. And what that does is it decongests the area more frequently. I think of it as sort of like flushing the toilet. You're just moving that stuff out several times a day, and it really decreases the amount of histamines, bradykinins, and some of the painful chemicals that get caught up with some edema. The other nice thing is if it's right after surgery, the patient doesn't have to actually touch the area. We know that using self-lymphatic drainage will allow fluid to move out of an area if you just create that nice siphoning effect. So we call that the hoochie hoochies at our clinic, and we call it that because it's lymph nodes are areas where you might tickle a child. And honestly, coming up with a silly name to tell our patients makes them remember it. It's a lot better than calling it abbreviated self-manual lymphatic drainage. So I'll just look at my patients and I'll say, did you do your hoochie hoochies today? I actually, when I have the opportunity, teach my patients how to do this right after surgery. So I've got some instructions right here, and we all know how to do this. So treating the cervical and supraclavicular nodes, then the axillary nodes, and then the groin nodes if it's appropriate for the patients. And I joke around a lot with my patients, and I say to them, well, we've got the neck nodes, and then when we get to the axillary nodes and they don't know where to push, I just tell them to grab as much armpit flesh as they can, do a bit of a pincer grasp, and just create pressure along that area. So I call it grab the beef, because if you grab that armpit tissue and you give it a little squeeze, not to pain, but just a squeeze, they remember that grab the beef word. And then the groin nodes, I call them the John Waynes, and I tell them that this is the only place that it's not really socially acceptable to do it in public. And so if you just put your middle finger in your groin crease and you lift up and in, and then sometimes I'll have patients actually bend their knees a little bit at the same time. So they look a little like a cowboy with their hands in their holsters on the sides. And that allows them to get a little bit of leg pumping and a little bit of muscle activation, helping to create the siphoning effect that we're trying to do. So I call it the neck nodes, grab the beef, the John Waynes, and then in the abdominal breathing, I call it the Incredible Hulk exhale. And I call it the Incredible Hulk exhale because I think a lot of an old TV show where Bill Bixby would turn into Lou Ferrigno, and he would make a big exhale and bring his arms towards his stomach and bend over just a little bit, and all his clothes would peel off, and then he would turn into the Incredible Hulk. And that, again, gives the patients a little bit of giggle and laugh, and that's part of what we're trying to do because we know laughing actually moves lymphatic fluid. So I call that the Incredible Hulk exhale. And that helps the patients, again, to remember it. And I tell them that you don't have to do it at the same time. Doing it in sequence would be nice, but if they have to get in their car and drive, and they might do their neck nodes, and then they go to the grocery store and they come out and they do their axillary nodes, and then they sit at a stoplight and they do the Incredible Hulk exhale, that works as well. But I think it gives the patients an element of control. We know that it improves the siphoning effect, and it gives the patients an opportunity to really get some of that fluid out, and they feel better. And then a couple of times a day, I'll have them do the swipe or the skin stretch, and just swipe the skin away from the affected area after they do this node clearance, and start to soften that tissue just a little bit. But if a patient presents with complications that independent management doesn't handle, then we have other options, and one of those is the use of compression or chip pads. And don't be afraid of using the chip pad about 4 to 6 weeks after the radiation has healed. So you want to make sure there are no open wounds and that they can tolerate pressure on the skin, that the redness is reduced and that's maybe turned into a little more scarring or some brown color to the tissues. But as soon as it's not painful to touch and the skin is healed, then there isn't a problem using the chip pads. And I have seen just remarkable changes in patients' breast tissue after you use chip pads and compression, and they don't have to wait for a year for that breast tissue to soften up. Sometimes it can soften up in as little as 2 weeks. It's quite remarkable. And then that radiation is going to keep going. The radiation changes are going to keep going. And then they may go away for a while, and then they get that, it starts to firm up again. They'll get the compression bra back out. They'll get the chip pad back out. They'll put it back into their against their skin. They might sleep in it at night versus wearing it during the day, which is also fine. And they get it back to baseline again. So that's part of that toolbox that I'm talking about. So giving them some opportunity to do self-lymphatic drainage, giving them a good compression bra, and then the chip pads and showing them how to use it can often keep them pretty comfortable. If the scarring is too severe, I'm a big proponent of cold laser and have been using it for about 20 years. If anybody has any questions about laser and treatment for laser, I'm certainly willing to talk to you after this seminar at any point in time. But I would say that it's reduced the amount of work I have to do on a scar by about 50%. And when you can get that much change in tissue and then you support that change with the compression and the chip pad, it's very powerful. I also like to use different techniques for scar tissue management. And one of those is a little reflex hammer technique that I will show in the next slide or two. But anything where you can use some tool-assisted myofascial release. I use cupping and suction. Sometimes I use a snake bite kit on some of the really deep and heavy tethered scars. Obviously, this is all within the patient tolerance, but those sorts of things can be really helpful for patients. Elastic taping is also very beneficial in some cases, and then of course treating that cording as needed. So one of the things I want to make sure we take a look at are the types of tissues that we need to assess. So when we look at the breast here, we see that there are lots and lots of layers that we have to go through. There's muscle, there's scar, skin, fascia, neural changes, and then joint and capsular changes. We also know that it's pretty common about 3 years after someone has breast cancer treatment to actually have shoulder impairment of some type or rotator cuff issues. And so we want to make sure that when we're treating these patients that we get as much range of motion back as we can, that they're not having any neural tension issues. I give patients self-neural glides frequently, and that we pay attention to the scars that might be connecting those areas and not allowing them to move. Just a quick look at the deep lymphatic anatomy here. Notice that there are lymphatic vessels that come around each rib cage right here. Another reason that breathing is such an integral part of trying to drain our chest wall and our arm, and that they have direct connections to this long thoracic duct, so it doesn't even have to go up through the arm to the neck and then back out. Sternal motion is another key to lymph movement, and I would challenge all of you to take a look at your patient's breathing. When they lie on their back and you put your hand on their sternum and you have them do a big exhale with a sigh, and I often will have them make a noise, which is ah, and then maximally exhale. Look at that sternum and see if it goes down, because that sternum should go down towards the chest and then drop caudally just a little bit. And if that sternum's not moving, then there's probably not a lot of rib motion. If there's not a lot of rib motion, then they're not getting the benefit of the movement of the ribs to help the lymphatics of the trunk as much. So take a look at that sternum and see what you see. Looking at breast lymphatic drainage, we see that there are different ways that we can drain the breasts. Some of them are kind of obvious. Obviously, we can go around the breast here, we can go around the breast here, but remember about those specific channels that go right straight to the sternum right here. And doing a little bit of pressure on the sternum will often help evacuate fluid from the breast. These are the paravertebral nodes and the sternal nodes right here in this picture. So use that to your advantage. Again, another good reason that the sternum needs to move during treatment, or during breathing, and then again during treatment. I have a technique that I use using a reflex hammer, which is something that's pretty easy to find around the clinic, and I'm showing it right here, where you fix one end of the scar and then you do very little wiggles, just taking up that slack. And the nice thing about a reflex hammer is that it has a little point to it and you can kind of grab that scar. I think it's hard to treat scars when the scar is tight in very squishy tissue, and breast tissue is very squishy, and so is axillary tissue. So being able to grab it and stretch it in the direction that it needs can be really, really helpful. So hopefully that's something that's quick and easy, and it'll give you some options. I've even had patients do it to themselves, although it's kind of hard to affix one end of the scar and pull on the other for some patients, but depending on where it is, it's not a bad thing. And I will often teach patients how to use a little bit of Dicem for scar management as well. So coming to some of the opportunities that we have for external compression. I developed the Bellisse compression bra in 1999 after I started treating patients and realized that there wasn't an option. And I was a design major before I was a physical therapist, so I knew a little bit about design and how to absorb volume in the trunk. And one of the specific things about this product is that it absorbs volume versus creating a vessel for breasts or a cup for breasts to fill up. And when we're trying to get edema out of the trunk, we've got to make sure that we want to get those breasts up and towards the chest wall. I call it the smush factor. And bringing those breasts up and pulling them into the chest wall allows for the shortening of those lymphatic vessels and for them not to, for the fluid not to have to come up from a pendulous breast and try to go sort of like up and over the hump. You want to lift them up and bring them into the chest wall. It's comfortable and adjustable. It has, some specific features that I'm going to go over in the next slide that make this a little bit better than some of the other options, and certainly better than a sports bra for most patients. Some of the features include a longer torso. So here we've got a zipper, gets the patient in and out easily. You'll notice that the seams come down right here. This is called a princess seam, and a princess seam is a space that absorbs volume, and that's how you can get a breast to fit into an area and have smooth fabric all around it. Notice that it comes down longer. So we attempted to come down towards the watershed because when the bra fits underneath the breast right here, that's when that tourniquet effect happens for a lot of people. So by bringing it down here, giving it a wider band, that's really helpful. We go over to this picture here. I've decided that a gusset would be helpful. A lot of patients would complain of dog ears or tissue that was spilling out over where a normal bra might be. And so we put in this gentle gusset, which actually has a cupped shape if you look at it from the side. And that gives the opportunity for that fluid to have some support while not cutting the patient. You can also raise and lower the gusset level right here by changing it in these straps right here. So we've got these Velcro straps that have a little bit of foam in them so that they don't dig or become narrow in the patient's shoulders. And so you can raise and lower this right here and then raise the level of this to this. So a lot of that is going to depend on where the patient's comfort level lies. I like to think about, like when we think about where should a sleeve come to on the patient's arm, you want to fit about 2 fingers in the armpit. And then have the sleeve start about then. So if I put this bra on a patient with a short torso, I might pull the strap down just a little bit or raise it up depending on what's going to be most comfortable for them. Over here you'll notice that we've got an inner what I call a floating bra, or it's an inner bra. And my idea for that was very similar to a Speedo swimsuit. When someone wears a Speedo swimsuit and it has that floating bra in it, it just elevates and pulls the chest, the breasts into the chest wall, and it holds it there pretty comfortably. Because you got to have something that comes underneath the breasts right here, or sometimes the breasts are pendulous, they fold over, and then that's actually more uncomfortable. So you want something that hugs underneath the breasts that actually lifts them up a little bit. And we've got 2 layers of lycra fabric right here, again with the princess seam going up, so it's the same contour as the outside right here. And this inner bra actually stops right at the side seam. So then again, you don't have anything coming around the whole torso. So you can see the line right here. This comes across, ends right here, and then this is just one single panel of fabric, whereas this is 2. So we've got more support in the front than in the back. We also have some hooks and eyes that allow the patient to hook up. It's hard to see in this picture, but underneath this panel right here are some hooks and eyes that allow the patient to put that bra on, hook, and then zip. We also have an extender that we created because sometimes we have patients who are going to wear a chip pad, or they've got a lot of swelling and it's going to go down post-operatively. And so it gives an option to actually have, instead of 2 or 3 2 inches of change right here, you can actually add another 2 inches in if you need to. So if you're expecting that patient to go down in size, you can use that. If you've got a patient that's going to wear a chip pad part-time and you need some volume, extra volume to absorb that, you can put the extra extender in there. And then we've also had patients on occasion who are up in the 50s, 50 inches around their torso, or wear 52s, 54s, and sometimes we can add that in. Once in a while, we'll get a patient that has a very hourglass shape, and you can actually change the way you hook these, and you can start it tight at the top and go down to the bottom like this. And that way you've got a wider space here and a narrower space at the waist. Or you can do it the opposite, and you've got some people with apple belly shapes, and you can do it tighter at the top and then kind of diagonally come down here at the bottom. And I have some better pictures of those in just a couple minutes. So what are the keys to fit? Well, it has to fit. It has to be successful for it to fit. So compression only works when it fits. And that's really hard for a torso. And we're very lucky to have these companies like BSN Jobs who can make us such wonderful fitted garments for the limbs, but it's very hard to make them for the torso and the breast because everybody's a different size. And then post-surgery, that even becomes a bigger issue. Something to consider is that breathing actually feels restricted at about 16 millimeters of pressure around the rib cage. And that's an issue because when we think about how much pressure we put on an arm, it's about, you know, somewhere between 15 and maybe up to 40 millimeters, 30 millimeters of compression. So the arm tolerates a lot more compression than the chest wall does. So those ribs actually need to move. So a good fit of a bra, of a compression bra, will have actually about 7 to 10 millimeters of pressure, which is not very much. Really what you're trying to do is overcome gravity. So in a large busted woman, if you have to lift, those breasts are being lifted up, there actually might be more compression needed or more support needed to lift up pendulous breasts than there will be for smaller breasts that don't need to be lifted up. So we can't really use the amount of millimeters of compression that are needed in an arm and extrapolate that to a chest wall. When we do the fitting, you want to make sure that you can slide about 2 fingers up the back at the hook. So at the base of the bra, which would be around here somewhere in the back, you want to make sure that you can get 2 fingers up there comfortably. Because if it's too tight, the patient will tell you. If it's too loose, the patient will also tell you that. So remember that the front should not gap. So in the front of the bra right here, there should not be gapping or space. It should fit pretty flat across the chest wall. But on the other hand, you don't want any breast tissue popping out at the top either. That's also not good. One of the things that I've found when I get this fitted correctly on a patient is that they will say, ah. They just kind of exhale and say, ah, it just feels so good. So I call that the ah factor. So really look for that and let your patients help you with what's comfortable. Because if you get too much compression in the chest wall, like I said, it will restrict breathing, but it also can, because there's not a lot of tissue usually between the rib cage and the chest wall, you can also restrict circulation just a bit too. So it's got to be really comfortable. So just a couple of exceptions that one might think about. There could be different body types. So you might see somebody with a narrow front and a wide back. If that's the case, you can fudge around a little bit with some of the measuring in the bra. And usually if I've got a patient who I'm going to try to fit, I have a good relationship with our local medical store, and I might ask the medical store to give them maybe 3 sizes, and I'll have them bring it in, and I'll look at which one is best for them. If you had somebody with a really wide back and a narrow front, you could also maybe use an extender to get so that the front is not too wide and covers the breast, because you want that side seam to be about right down through here. So you don't want the side seam coming around the back. Right in the middle is good. So if they have a wide back, consider using an extra extender. There's also an issue with some short-waisted people. And so in trying to make the magic length of this bra, one of the things that I figured out was that if I just unhook the bottom 2 hooks for the patient, it actually can give a little spread or a little widening. And I'll also have patients do that sometimes when they're having to do a lot of sitting. So with having a bra that comes down to the base of the rib cage, you run a little bit of risk of them feeling like it's cutting them off when they're sitting. So leaving those bottom 2 hooks undone can be really comfortable. And I'll show you some pictures of that in just a few minutes. Remember that larger busted ladies need a little more lift. So you might have to cinch the straps up a little bit. But also, the majority of the support of this type of bra is really coming from something that I call smush factor, which I used a little bit earlier, which is also sort of like a tube top. So because the bra is wide in the back and it's fairly wide in the front, it actually gives that patient circumferential support. What do you do when someone's had a mastectomy on one side? Well, on the occasion where you've got a very, very large breast on one side and no breast on the other, that can be a bit of a problem if they're choosing not to wear prosthesis. But if they're wearing a prosthesis, you'll just put the prosthesis in place and then measure them and make sure that it's comfortable for them. Patients that aren't as large busted, because what you're trying to actually do is get a bit of smush factor, of course it has to be comfortable smush factor, but some smush factor going on, then because this bra is fit around the chest wall and it's not 2 cups that are holding breasts, you can actually take that into account with the measurement. So if someone's not going to wear a prosthesis, you'll measure around the torso. So we're looking back up to here, like how do you measure this? The first thing we do is we measure through the center of the bust line right here. If there's only 1 breast there, then obviously that measurement's going to be slightly less than if there were 2 breasts. And believe it or not, for a lot of patients, just reducing that volume will allow the bra to fit them fairly comfortably. The other place that we want to measure is right under the bust line right here, which is the normal place that one would wear a bra. But because this bra also comes down lower, we also want to take a measurement here. We all come in different sizes and different shapes, so it's not uncommon for someone to have maybe this 1B line be actually a larger number than the 1A line. So we want to look at these 2 numbers, and what we're going to pick is the larger number. So we've got a number here, and we've got a number here. Then we want to go down and look at the cup size, and we want to say, okay, I've got a number here, and I've got this number here. I'm going to pick the larger of the 2 sizes, and then I'm going to, let's say that this is 38 inches. I know we've got some centimeters down here. You can do centimeters or inches, but let's just say that for inches sake, we've got 38 here, and we've got 34 here because it's a very small person. So we've got a 4 centimeter difference. So 4 centimeters is going to, 4 inches, and then that's going to be about maybe plus or minus 8 centimeters difference. So that person might be comfortable in a CD bra right here because you're taking that subtracted number. So this number subtracted from this number. If you've got someone who's got bilateral mastectomies, then they're just going to automatically be an AB size because that's a very flat size. And sometimes I will have to look at the size of the breast and how much compression it actually needs. So there might be somebody who measures that they would need a central or a CD size, but I might put them in an AB size just because I want a little more compression. So that's why it's kind of nice to have the opportunity to try a couple of the bras on. I mean, if we think about it, anybody that buys a bra at a store anywhere is going to have to go in and try on several different sizes. So I think that for us, it's a little difficult when we don't have just a couple to try on. So again, if you have that opportunity in a relationship with a store near you, it's really nice to be able to have that patient bring in 2 or 3 sizes and then return the ones that are not as good for the patient. And remember that if the patient is going to wear a pad under the bra, to account for that in the volume, and you'll want to measure the pad on them when you're measuring for the cup size or for the torso size. So put the pad where it's going to be. So maybe it's going to be on the side right here. And so you'll put it on the body and take that tape measure and go around on it. And if there's any more questions about fitting specifically, I'm happy to answer them at the end or at a later date. So what's a Jovi pack? It's a great company that makes great pads that help with fibrosis and help with scarring. And it's been around since 2000. And the nice thing about the Jovi packs is that they use different blends of shredded foam. And to me, that's really important because that's where you get your high and your low pressure changes. And that looks a little bit like this. So if under thermography, you can see the warmer colors are actually where there's higher temperature, and the lower is where it's cooler and there's not as much fluid in that area. So what we see is these different pressure changes that are happening between the stitching channels, and that creates this type of effect on the tissue. And it helps to add a little more force to the fluid, it helps it to move out, and it also softens that scar tissue really nicely. So we make these different pads to go with the Bellisse bra, but I don't want anybody to get stuck in like which pad goes for which thing. The really important thing is that the pad covers the area that you're trying to treat. So in this particular case, we made a pad that actually fits inside. There's a little side seam that's open on the inside of the inner bra, and what that does is just allow you to either put a prosthesis in it or you can put a pad in it, either one, or sometimes both. But again, don't get stuck on the fact that it has to fit right there. The important thing is that it fits where it's supposed to. All of these pads are made with Polartec and Power Dry, which is really nice because the patients really don't find them hot and they're quite comfortable. And we can have custom pads made for patients. We've seen patients that have large indentations in their chest wall from tissue changes or scarring, and we can actually make different size pads that will fit into those areas so that if you're needing to get pressure in a concave area, you can. Here are some other shapes that we have available. We call this the serratus pad. It comes around the sides like that. So for the patient that's got edema here, you'll notice that these continuous flow channels are coming up like this, and they are just, again, trying to take all that fluid and direct it towards what I call Rome, which is the axilla. This is for a patient that maybe needs to sleep in it. Maybe this person doesn't need a bra over it because it actually has a Velcro closure. And a lot of times I'll have patients sleep in these, and then they don't have to wear them during the day, and that can be quite comfortable. This is a cleavage pad that we made that goes in so that you get a little bit of foam and support on the inside of the chest wall. Here's another one that comes down and kind of brings the fluid up from the lower end and directs it out the back. This is what I call the Madonna pad, but this also works great for total knees, by the way. But this is a great pad for patients who have quite a bit for a larger bust and need that fluid to move out from around the whole chest wall, and then these channels are taking it up this way. This picture is here because I'd like to show you something that Jovi Pack came up with, which is quite innovative, using cherry pits. So they are cleaned cherry pits, really from cherries, and they sew them in like little beans into the pad. So if you've got somebody with woody fibrosis, this can be extremely helpful in taking down that edema. We also make a particular pad that goes into the axilla. I have a number of patients that will sleep in this, and it helps with their axillary edema. We also made a pouch for a drain, so if a patient has a lot of edema in their chest wall or a seroma, they can wear this and still have their drain in if needed. But this is a really comfortable pad that I created with a physician named Dr. David Craig, and he was one of the first physicians that developed sentinel node biopsy, which was adapted from melanoma to breast cancer. And he was quite concerned about patients in the seromas that they get in their axilla, so we created a pad for this. It's quite comfortable. Just to show you some quick patient pictures right here, and you can just see that this is a patient with some lymphedema, also had breast cancer, but you can see that right here is bigger, this is smaller. We've got it on the widest hook, and it held in this side quite nicely. Here's a picture of another patient. You can see she has quite a bit of edema on this side from breast cancer, and what we did here is we changed the hook situation. And then we opened up those lower hooks because she was a little shorter and a little broader, and we were able to make it quite comfortable around her waist so she could sit and it didn't feel like it was constricting her at all. And it holds in some more of these curves right in through here. Here's another patient who was going through radiation, and you can see that she developed quite a large pouch right here. And so we put her in a Bellisse bra, again, spreading it right here at the bottom. And it held this in quite nicely. The edema went down quite nicely, and she was much more comfortable. And lastly, I'd like to talk a little bit about when edema isn't edema. And this patient was sent to me from the middle part of the southern part of the East Coast. And she called me and she said she'd been treated for 7 months for edema in her arm. She had been taped and wrapped and bandaged and had garments and was really incredibly uncomfortable. I told her there wasn't really anything else that I could do for her that the therapist wasn't doing for her. We sent her to the Foldy Clinic with her husband, and she was diagnosed with inflammatory breast cancer. And this patient had been seen by 7 physicians and multiple therapists and had not been diagnosed with this. So one thing to remember is that even though inflammatory breast cancer is not that common, remember that when edema doesn't respond, you want to make sure that you don't just treat and treat and treat, because if it's lymphedema or edema, it really does get better. So here's just what her breast was shrinking. She had scarring in the upper extremity. And then a year later, it had just progressed even more. She was using a little bit of tape there just for some comfort, but you can just see that it was really, really progressing. So just remember that the signs and the symptoms of inflammatory breast cancer, and that arm edema doesn't necessarily mean that there isn't something else going on. And finally, when clinical observations, remember that our body's always trying to restore homeostasis. We have the ability to increase the lymph system transport capacity by creating this siphoning effect through MLD and self-MLD, which is very, very effective. It gives patients a little bit of control too. Patients who participate in a regular self-care program anecdotally have better control of their edema. And when they're given early compression, they have less pain and less edema, and they can control that post-operative radiation scarring. And giving a patient an element of control is very, very empowering. And lastly, I'd like to thank you very much for your attention. And I hope that this was helpful and interesting, and I'll be happy to take some questions at this time, or you're welcome to contact me separately if you have any specific questions. Thank you very much.
And this is Marissa. I'm with Marketing Lymphology at BSN Jokes. And if you guys do have questions, there's a way that you can type your question. So if we see any questions come in, Leslie will address those. Also, feel free, if for some reason you came in late to the presentation or want to review anything, feel free to reach out to me by email. Any of the emails you've gotten about this webinar, you can just reply. There's an email to reply to, so just reach out to me with any follow-up questions you have, or if you would like a recording of this presentation. And there are some questions. Leslie, can you see the questions? Leslie, are you still on? Okay, Leslie, go ahead. You should be able to get the questions now.
Okay, but I can't see any questions. Can you read them to me?
Oh, okay. Yes. So does Medicare cover the Bellisse bra?
Medicare does not cover the Bellisse bra, but it also doesn't cover any other garments. We're still fighting that battle in politically right now. But most other insurances do. It's covered by, in Blue Cross Blue Shield, it's covered by Medicaid. It's in our state anyplace, and it's covered by Kaiser. It's covered by, it's actually covered now pretty much as if any compression product would be covered.
What parameters do you use for laser?
What parameters do I use? I am using a cold laser, and the cold laser is a 904 nanometer wavelength, which means it's in the invisible infrared spectrum, and it does not produce any heat. The one that I use is a single diode. It's handheld, battery operated, and you don't need goggles. And if anybody wants to talk to me about that further, I'm happy to talk about it.
Okay. So you might have just stressed this, but if someone has a cold laser, do you have a protocol on how to use that?
If you have a cold laser, I find that using, again, the lasers are all a little different in terms of how much energy they emit at the time that you're using them. But really, the general principle is to use it long enough that you feel an effect. So I would take my finger, I would feel the scar, feel the thickness of that scar, and then I would use the laser, at least the one that I use, for about between 60 seconds and maybe 2 minutes. And sometimes I'll even use the tip of the laser, which is a little bit pointy, and I'll actually stretch the scar with a little bit of pressure, almost like using tool-assisted myofascial release, using the laser for that purpose, and it's very effective. And so most of the time, at least the laser that I have has a 2.5 centimeter spread, and so I will sometimes cluster the laser and use it in a circle or in a line and maybe move it a little bit closer, so I'm overlapping some of that energy that I'm putting into the tissues. It's very, very effective.
Okay, great. And someone asked just about truncal thrombosis.
It happens. That's one of the patients that I showed you. I didn't actually see that patient during the time that she had the thrombosis, but I'm treating the post-thrombotic pain effect for that patient right now, and the lymph drainage is very, very effective. It'll give her about a week to a week and a half reduction in pain. I also use tape with that particular patient, elastic taping, and we tape her scars and we redirect fluid as much as she can. She also wears a compression bra, and then when it's really uncomfortable, she actually wears a pad at night.
Okay, great. And then can you speak to fitting a patient with a Bellisse bra that normally has a large cup size, example size G?
That's really big. That's where you might have to play with it a little bit, because you know, a patient that's that out of the norm, or out of the normative values, that is for most people, is going to be challenging. But that's where I've taken patients and I have used the largest cup size, and I've just started adding extenders to them. And that actually can work very well for a patient that size. That's why I made this bra so big to begin with, because when I was having patients come in and they were in the 50s in terms of trunk circumference, that was not the moment in time when I just wanted to say to them, well, you know, if you lost a little weight, this would be easier. That is not the time to say this to that patient. I mean, certainly that's something that would be beneficial for their health in general and help control their edema. But in that moment in time, they need relief. So I would try playing with added extenders. If that doesn't work, then I think that the patient might do well with a custom vest. And I have ordered those for patients as well, because Joby Pack will be happy to make a custom vest that can be as big or as long or as wide as that patient needs it to be. And if the patient has a mastectomy on one side, they can actually fit the vest so that it has space for a breast on one side and can be, you know, accommodating to where there is not a breast on the other side.
Okay, great. And the last question is, do you have a code for the compression bra that you use?
We do not. My understanding from talking to the different medical providers out there is that they're still using there's a code out there for quote other, and I don't know the number of that code. If someone, I could certainly find that out if somebody needed it, but they're using the other code. And since most of the products that, especially the custom products for the arm or wherever, have to go through some kind of process of being okayed by the insurance company, usually they'll see the compression bra and other for that code. And we haven't had any problems at all for many, many years getting any bra covered for our patients.
Okay, great. Yes, somebody just messaged in. They use A6549.
Thank you.
Yes. All right. Well, thank you guys so much for listening today. And Leslie, thank you so much. We hope you've learned a lot. And again, my name is Marissa, and I'm going to send out an email with the PDF of slides. And if you need the recording of the PowerPoint, just reply back to me. In that email as well, we'll have all of our medical advisor contact information. So if you have more specific questions, there's me, there's Leslie, and then your local medical advisor. Thank you guys again, and look out for an email about our next webinar. We're going to be doing one about TheraWrap and billing. That will be probably the second week in May. In the email I'm going to send out, there will be a link to register for our email blast, and our email blast will have more information about the upcoming webinars. So try to get on our put your email down to get on our email blast list so you can be aware of new and exciting things we have coming for you. Thanks again. Bye-bye.